Thank you very much for the introduction, and I just want to say that I'm honored to be here in this great event, and I want to thank the Toshiba for the invitation. I was invited to talk about the application of MRI in MSK radiology, the clinical application, and I chose to speak about Hip MRI because it's a quite hot topic and with some controversy behind, and I hope to talk about this for a few minutes. How this works. Oops. That way. Okay. I would just to thank also my dear colleagues in Lisbon that helped me to prepare this talk. And I will, for the next 20 minutes, talk about the hip pathology and how MRI can be applied to it. I won't talk about extra-articular pathology because for the sake of time, there is no time for that, and there is more important things to show with these new machines that we have for intra-articular pathology in the context of femoral stabular impingement, and talk about some types of femoral stabular impingement and also with the consequent chondral and labral lesions. Hip pain is a common clinical issue in patients of all ages, and it's particularly important in young adults. That can be a symptom of something getting wrong inside your joint that will predispose you to have early onset of osteoarthritis. That's something that we don't want our patients to have. Since the beginning of this century, so there are a lot of advances in understanding of the anatomy, biomechanics, and pathology of the hip joint, and the role of acetabular labrum and cartilage in pain and hip degenerative changes is now well established. The possibility of hip arthroscopies now in surgical treatment has evolved and determined the need for accurate non-invasive imaging assessment that MRI is in the right place and can provide. Well, this talk is about MRI, but still the plain film is very important in the initial workup of the hip pain, and it's a good guidance for further imaging, so we still need to be careful about that, and especially when you look at the femoral stabular morphology, you need to be careful about control quality of your criteria quality of your x-rays in terms of alignment and tilting, as you have these criteria that you always have to look about. Well, MRI, several advantages. There are just few of them. It's a radiation-free technique, as we'll talk about a lot of radiation in this symposium. Multiplanar and multiparametric capabilities with high soft tissue resolution that no other imaging can provide us, and allow evaluation of inter and extra-articular causes of hip pain, and I will talk only about the interarticular, as I told you. Well, although it's a powerful technique, it should be performed in 3T or high field, high strength magnets as the 3T, and we do now. We are happy to do it on our new Gallen 3T. It's a protocol that is with small field of use, only focused to one hip with high spatial resolution in 20 to 25 minutes. Is one of our longest protocols. And it includes axial T1, coronal oblique proton density with and without fat suppression, sagittal oblique to the neck fat suppressed proton density, and axial oblique to the neck, also fat suppressed proton density. We further do two global imaging of the pelvis. So one is the axial, the fat suppressed proton density of the pelvis to look for extra-articular causes of hip pain, and also we do the 3D quick axial that allows us, as a volumetric isotropic technique, acquisition allows us for multiplanar reconstructions, and it's important for a stabular evaluation, as I will tell you later. Of paramount importance when you look at the MRI of the hip, and you should do it in every hip that you image, it's the radial images. We perform direct acquisitions in fat suppressed proton density, allowing for a global view of the acetabulum on all around the clock, and then you can, as you can see on these images, you can look for lesions that it's like this one, and you can exactly locate it by cross-referencing your images and help to guide your surgeons toward the repair. Well, we also perform arthrographies, and how we do this, there are two ways. There is indirect and direct way. The indirect way is performed by intravenous injection of gadolinium that will go into the hip joint by a transsynovial way, and without the need of any intra-articular injection. Well, that's the way the patients prefer. We prefer the other way, the direct way, where we inject intra-articular gadolinium by fluoroscopic guidance, because we prefer because we have a good joint distension and a better accuracy on labral lesions. Well, talking about accuracy, how we do perform, well, this meta-analysis recently published, they compared different types of MR studies, the direct and the indirect arthrography, and also the conventional MRI for detection of chondral and labral lesions in the context of femoroacetabular impingement. Well, they concluded that the accuracy was superior for the direct MRI when compared to conventional MRI, and also that any of our methods are superior in accuracy for labral lesions when compared to detect chondral lesions. So we fail a bit in the chondral lesion still. Well, also they concluded that there are not sufficient data about indirect MRI for fully assessments of its diagnostic accuracy. Well, this is the end of the first part, and I want to share the picture that I first took when I arrived here, and it's an incredible picture, and I'm kind of proud, and it was suggested that I put it here, and I just put it, and I think it's a good picture. Well, let's now talk about femoroacetabular impingement. Well, it's some of debatable topic and with some controversy. Well, it's a well-established syndrome with characteristic clinical and radiological findings. It results from the repetitive impingement of the articular soft tissue structures, mostly the labrum and the cartilage, and it's leading to their damage and finally to the hip pain. Well, it has been associated with extreme repetitive motions, that's why it's more frequent in athletes, and it's with specific morphotypes and deformities, and that deformities allows us for classification of femoroacetabular impingement. So if you have the deformity at the acetabulum because you have an over coverage of the acetabulum with a normal femoral head, then you have a pincer type. Or if you have the problem and your deformity is in the head of the femur, so the junction in between the neck and the head, with the normal acetabulum, you have the CAM type. So the mixed type is the mixed type. They mix both deformities in the same patient, which is quite common. Well, normally it affects young adult athlete males, that they are, like as I said, more frequently they are CAM or mixed type than pincer types, and clinically they present to the orthopedic surgeon as pain and decreased range of motion with the positive impingement clinical test. This is the clinical test that should be performed by the orthopedic surgeon, and it's very important that they give us this information because there is no single parameter, radiologic parameter, that can diagnose the impingement itself. So the impingement itself should be a clinical finding and not a radiological finding. Well, there are some open questions taking care about real prevalence of the disease, and there are some doubts on the data quality. And the link to osteoarthritis is well established with the CAM deformity, but not so well established on the pincer deformity. And furthermore, there are some, it's very common in asymptomatic individuals to have the morphotypes that are associated with the impingement, and there are still some definitions to be done and thresholds to be found. So I'm going to start to talk about a bit of the CAM impingement. So the CAM impingement is the result of the normal femoral morphology with the normal acetabulum, typically seen in young athletic males, as I told you before, and this kind of bump that you can see, this kind of bump, it's like a pistol deformity that is very, very associated with this type of impingement and is defined by the excess of bone at the head of the neck junction beyond the perfect circle fitting the femoral head, as you can see on these x-rays and also on this MR. Well, we always try to quantify, and trying to quantify that this deformity was proposed in 2002 with the alpha angle. So this is the angle that is formed by the axis of the neck and the line that joins the center of the femoral head and the junction between the head and the neck. So where the radius of the neck surpasses the radius of the head. And the threshold suggested in 2002 was that all patients with this kind of deformity has a 55 degrees alpha angles. Well, now we've been using this for some years, and we know there are some problems about this, and we know that there is incredible inter-observer variabilities, and there is elevated angles in asymptomatic patients, as I told you before, and the threshold that was suggested, it's fairly sensitive, but it's not specific enough, so it's not reliable for the diagnosis. Well, taking this in mind, our institution performed this study and published recently, where we gathered 3D information, and we looked for alpha angles on asymptomatic patients that show CAM deformity, and we gathered 188 hips, and we found that even with higher thresholds, we found 90 asymptomatic hips with the CAM deformity. So we were trying to find some measure that will help us, guide us, so we proposed the omega angle that is based on the three-dimensional evaluation of the head and neck junction. So it gives us the extent of the deformity in the transverse plane of the head and neck junction. Maybe it could help us someday. Well, what's the problem of the CAM type of impingement? There are the chondral and the labral lesions that they provoke. So they do chondrolabral separation and, chondrolabral separation, normally located at the anterosuperior quadrants, and also frequently associated with contracroup lesions that are on the opposite side. Well, cartilage lesions, as I told you, sometimes they are difficult to pick on MRs. Well, especially these kinds of lesions that you have, which is delamination lesions of the cartilage, where you can see the high signal intensity on the base of the cartilage and the hypointensity at the surface of the cartilage. Well, sometimes they are very, very, very subtle, less in this case. Well, the other cartilage lesions that are more extent, like the full thickness lesions, are easier to depict as this grade 4 lesion, associated with subchondral sclerosis, and also in this case with ligament teres rupture. Well, labral lesions, they are fairly depicted on MR, like this partial thickness lesion of the labrum, and also you can have here another example of a full thickness tear with a paralabral cyst. Well, herniation pit is a well-known lesion. It's a fibrocystic lesion that now we think about it as a consequence of impingement, and it's seen here as on this photograph of the arthroscopy, and here depicted also in MR and X-rays. Well, there are lots of classifications and way to classify the chondral and the labral lesion. There is something that we have to keep in mind, that there are many complex associations between chondral and labral lesions, and that's the intent of this slide, not to give the classification itself. Well, the pincer, as I told you, the pincer type of impingement, it's related to overcoverage. Can be overcoverage, general acetabular overcoverage, as in protrusio acetabular coxa profunda, or can be focal overcoverage, like in retroversion, acetabular retroversion. What we'll have multiple impacts to the labrum and to anterior acetabulum that will lead by repetitive motion and repetitive trauma to degenerative changes of the labrum and lesion of the chondrolumbar also junction. Frequently, it's also associated with Konter-Krupp, as I told you before. Well, the X-ray is still very important, the initial evaluation of the pincer impingement. So, in the X-ray, you can have a notion of the acetabular overcoverage, and as well as the lip of the ring of the acetabular. So you can evaluate for retroversion, as well as for coxa profunda or protrusio acetabuli, like on this case. Well, the normal acetabulum should be inverted. That is to say that the posterior wall should lie laterally to the anterior wall, as you can see here on this X-ray. The retroversion, the acetabular retroversion on the other way around, it's the superior part, normally the superior part of the posterior wall lies medially to the anterior wall, giving the very well-known cross over sign, and it can also be evaluated on MR. Well, but we have to be careful when we evaluate this retroversion on MR, and that's why we need the 3D quick acquisition, because it's an isometric volumetric acquisition. So what we do is we do multiplanar reconstructions in a way to correct the pelvic tilt, and we have the very well notion of the version of the acetabulum, and you can see on this case that before correction there was acetabular retroversion, and after correction you get a normal acetabulum. Here is a video where you can see the influence of correcting the axial plane on the acetabulum. Look here, it seems like a acetabular retroversion, but then when you correct the axial plane to the tilt of the pelvis, you see the influence on the perspective over the acetabulum, and you can give the right notion of version. Well, what's the result of the pincer type of impingement? Normally, it gets the labral degeneration, which is shown as high signal intensity, diffuse on the anterior superior labrum, and in the extreme cases with ganglion formation. Labral ossification is another phase of degeneration that can be easily depicted also in X-ray and on MR. Other findings that can also be found, like acetabular roof cystic changes, and also roof sclerosis and labral clefts. Well, in conclusion, X-ray is still very important for the workup of the painful hip. MRI is the most comprehensive non-invasive technique to characterize the hip pathology, particularly in the case of the impingement, using appropriate image techniques and protocols. MRI accuracy is superior for labral lesions compared to chondral lesions, and the accuracy of chondral and labral lesions are superior for direct MRI when compared to conventional MRI. Also, some asymptomatic patients will show radiologic deformities related to the impingement, but that's not to say that they have a femoral acetabular impingement, and there is no radiologic single parameter for the diagnosis of impingement. Thank you. I hope to see you soon in Lisbon for the annual meeting in 2019 of the European Society of Musculoskeletal Radiology to know our beautiful city of Lisbon. Thank you.